Welcome to the American Indian and Alaska Native Behavioral Health webinar series. I'm Kate Trams, and today we have Michaela Gray and David Welch joining us to present Mental and Behavioral Health Considerations for Native Transgender Individuals. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more about the ATTC network, please visit our website. Coming up in February, we will have a session on clinical supervision with cultural considerations led by Robert Rarrett and Sean Baer. And for our Essential Substance Abuse Skills series, we will have Dee LeBeau-Hein joining us on January 20th to present referral, service coordination, and documentation. So I hope you'll all join us for that. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The request form is available for download in the Files pod in the webinar screen and will also be sent in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GIPR evaluation. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. If you'd prefer, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as an inactive, and which may be reflected in the number of CEHs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. So today we have Michaela Gray and David Welch joining us. Michaela Gray is the Deputy Director of the National Native American AIDS Prevention Center in Denver, Colorado, and David Welch is a family therapist at the Denver Indian Family Resource Center in Lakewood, Colorado. And one thing that we are really excited about is that both Michaela and David are currently attending our Leadership Academy this year. So we're really excited to have them, and I just want to welcome both of you, and I'll pass things over to you at this time.
Great, thank you very much. And welcome to the webinar, everybody. And wanted to also thank David as well for being part of this discussion. So this is our presentation title, Mental Behavioral Health Considerations for Native Transgender People. And again, this is a discussion that I think many of us have had in circles around the country, and whether or not they were formal discussions or informal, I think that this is a great platform to have this here, and hopefully this will give you a little more information about transgender people and the mental health components that may or may not be impacting these individuals. So I myself, and just in a full disclosure, am a transgender woman. I come from Navajo land, and so I'm trying to figure out how to do this. I'm just going to advance my slides. So my name is Michaela Gray, and I work with the National Native American AIDS Prevention Center. And I started my transition about 8 years ago. And if anybody has any questions about that, they can email me and ask me at that time as well. But in brief, let me just start with this slide here. Transgender people are often overlooked and misrepresented when it comes to talking about healthcare. Transgender health is complicated and is new territory for most healthcare providers. And in order to provide comprehensive healthcare, transgender individuals need access to that mental health, behavioral health, substance abuse portion of healthcare discussions. So this webinar is intended to provide healthcare providers and those in the auxiliary as well some additional insights into transgender mental and behavioral health. And that's why I asked my colleague and Leadership Academy participant, David Welch, to join me in this webinar because he has a wealth of information in this area. So in brief, this is our overview for today. We're going to do some welcoming introductions, and I'll get to David's introduction as well, too. We'll go over some transgender terminology, talk about comprehensive health care as well as health disparities. And these are just going to be brief slides about this kind of thing. These will get dedicated presentation time, a whole presentation slot to those discussions. We're going to talk about mental health considerations for transgender individuals as well as the mental health process. And David has a wealth of information, like I said, about that. And then we'll round out the entire discussion with practical tips for providers. So the National Native American AIDS Prevention Center is, definitely focused on eliminating and confronting HIV and AIDS. But in addition to that, it's also concerned about those organizations are very concerned about the health and social determinants that negatively impact American Indians, Alaska Natives, Native Hawaiians, and other indigenous peoples. We were located in Oakland, California, but have moved to Denver. And I think we've been around since 1987, so we've been doing the work for a while. And we are happy to continue it. So I'll turn it over to David for his introduction as well as his organization's mission.
So my name is David Welch. I am the family therapist here at the Denver Indian Family Resource Center. And our primary mission is to strengthen vulnerable American Indian children and families through a lot of the culturally responsive services that we offer. With collaboration with other agencies. Almost everything that we do comes from a trauma-informed lens. And so my specialty actually comes from that trauma lens and how we work with families with the understanding of, the cultural competency tied into historic trauma and how that influences the current traumas or the current mental health issues we deal with in our community now as mental health providers.
Wonderful. Thank you, David. So again, we are participants of the 2015 American Indian Alaska Native ATTC Leadership Academy. And I believe there are 10 mentees, and each of us has an associated mentor. This photo was taken in Iowa in August of actually last year. And we are looking forward to our training in January, which is actually happening next week in Florida. So we're happy to see each other again face to face. But yeah, you can see David off to if you're looking at the screen like I am, it's way off to the left, and I'm kind of center. So anywho. So another piece that I wanted to highlight, of course, was the National Native Transgender Network. So in 2013, a group of transgender individuals came together and were highly concerned that they had heard gay men, let's just say that, were being asked to speak on our behalf about our health issues, about our health concerns, about how we live as transgender individuals. So they started formulating a group of individuals who are professionals, who are community members, who are openly transgender, to accurately represent individuals or accurately represent the Native transgender community. So with that, we formulated the National Native Transgender Network, and we're happy to do the following. Provide Native transgender health information as well as other information on pertinent issues surrounding this transgender individual. Provide transgender 101 discussions as well as cultural sensitivity trainings. And our target audience would be those who are healthcare providers, service provider organizations, as well as other entities who work with Native transgender individuals. We also want to participate in the advocacy of public health issues impacting Native transgender people. So, of course, things like hormone health care, mental health services, things of those natures, we definitely want to be a part of those discussions. We also want to give opportunity to mentor the next generation of Native transgender people, whether they're Native transgender women or Native transgender men or somewhere in between. We definitely want to help in that process as well because we have a wealth of information. We have key access points for healthcare questions. So definitely look for our Facebook page. We have one, and reach out to us there if you have questions, if you have a presentation you may need us to do at some point, and we will allocate somebody in that area to go and provide that training. So we're working on standardizing some things as well, too, in that group, so bear with us and give us a little more time, but we will have our hopefully on a website of some sort. So nonetheless, here we go. So let's start out with some definitions and terminology, and David can help me out in a couple slides here. So let's see here. The transgender definition literally means across gender. Sometimes it's interpreted as beyond gender. It is a community-based term that describes a wide variety of cross-gender behaviors and identities. This is not a diagnostic term and does not imply a medical condition or a psychological condition. So avoid using this term as a noun. A person is not a transgender. However, they are a transgender person, a transgender male, a transgender female. So keep that in mind. Okay, so David, do you want to talk about this slide?
So from a mental health perspective, when we're working with clients that identify as transgender, we're using that as an umbrella term for people who challenge those boundaries from their sexuality, the gender. And so with that umbrella term, that'll include people who openly identify as transsexual, transgender. There is a component of society that will also use that to include cross-dressers, drag queens, and individuals who, again, they cross what we consider the socially accepted, norms for gender identity or sexual expression. And so part of what we have to do as mental health professionals is work with the individual for exactly how they identify in this, so they're not using the umbrella term, that we're using the term that's specific to that client.
Okay, great. Thank you. And this is just a little graphic that shows that the trans umbrella. We've got trans non-binary people. We've got the trans men under the umbrella as well as the trans women and cross-dressing people. So just know that it's an umbrella term and that it describes multiple different people. So the key is to ask, how do you identify, if that's up for question. Okay, so, and David, you want to talk about this as well?
So when we shorten it to the term trans, it's used as a term for individuals who are called transsexual. And then generally this is assumed for individuals who are transitioning or have already transitioned to the gender opposite of their biological birth sex. So, when we're looking at the transition male to female or female to male, that will include choices about how they dress. The big part of that, I would say, is the hormone therapy, because for either transition, the hormone levels can drastically affect medical as well as mental health concerns. And then moving on to even the surgical intervention if the client so decides that that's what they need. But the big part of it, at least from my experience working with clients, has been the hormone therapy piece of it. How do we regulate the moods? How do we regulate, whether it's increased aggression, decreased aggression, all those kind of things. And so when we look at the hormone emotional flood, the way it affects the hippocampus, how can we help the client understand their new normal based on, the things that they have to experience while going through the transition.
Thank you, David. Thank you. So as David mentioned before, there are those who are male to female, transgender individuals, and there are those who are female to male. And again, individuals that were born male will transition into being female through lifestyle, through hormones, intervention, through surgical intervention, and or may not at all. They may just want to. So just keep in mind that there are various stages of this whole gamut, and individuals may participate in a limited fashion in the transition process or do the whole full gamut of interventions that are available. It also depends on their socioeconomic status, their educational level, and just their, in general, access to health care and being well informed of how to do this appropriately. And again, we do have individuals who seek the black markets and will utilize products from that black market in order to transition. So just keep in mind that there are individuals who, depending on what they have access to, depending on what they can afford, will access various medications and such. So again, male to female and female to male. And it's okay to ask individuals, are you male to female or female to male? So just, again, when in doubt, please ask. Additional considerations are transgender patients come in all shapes, sizes, races, socioeconomic levels, as well as educational backgrounds. But the core of this is that their bodies don't match their gender identity or gender presentation at the time that you meet them. So they may have had or want to have medical treatments to modify their bodies to affirm their gender, but they may not have had any of that. So it depends on how they want to be referred to when you meet them. It just, as David mentioned before, it just depends on how they want to identify, as well as disclose how they would like that to take place. So using terminology, again, if you don't know, please ask. The community definitely appreciates those questions. They may be a little awkward at first. And so, again, when in doubt, just ask individuals, are you a transgender individual? How are you a transgender male to female or female to male? Just breaking it down to those basic tenets definitely helps encourage discussion. Make no assumptions about gender confirmation surgery. So formerly called SRS or sexual reassignment surgery, it's now called gender confirmation surgery. So not all of the transgender community wants to have that or can have that, depending on their health status, depending again on what finances are available, and just depending on their support system as well too. If you make a mistake in using the pronouns, acknowledge it and then apologize. So at least when that happens immediately, that the individual knows that you are making every effort to acknowledge who they want to be right now, acknowledge what they're presenting as, and acknowledge that the new name that they prefer is being used at this time. David, do you have anything to add about this?
No, that pretty much covered a lot of it. I think the big piece of that is the assumption part of it. I think a lot of therapists tend to make the mistake on the assumptions. And so that's where we need to check ourselves when working with clients that come from this particular segment of the community.
Thank you. So let's just talk briefly about epidemiology. And let me see, I do have pie charts as well as words on these slides. Okay, so transgender women are at very high risk for HIV infection, according to the 2010 CDC reports. Of those who tested positive that year, transgender individuals and the transgender population had the highest percentage of a new HIV acquisition. So again, this is represented in this pie graph here. And again, so let me just break it down even further. So when we look at the transgender community, who is it? Again, it's transgender women, but is it the white women? Is it the women of different races, or what is it? So we broke it down a little bit here. And again, the highest new HIV positive test results were among those who were of ethnic minorities descent. African Americans are the highest, next were the Latinos, then the American Indian, Alaska Native, the Native Hawaiian, and other Pacific Islanders as well too. So clearly documented here in this pie chart as well. So when you're working with Native transgender women, know that there is HIV risk there, that they may be an issue in that person's life, that this person may or may not be living with HIV, this person may or may not be at high risk, but just know that just having it in the back of your mind may help kind of inform some of the things that she talks about when she's with you. Health disparities in comprehensive health. So let's just cover that really fast here. Disparities. So among the transgender community, we have the highest rates of the following: drug and alcohol use, incarceration, being homeless, engaging in sex work in order to survive. That should have said survival sex work. Unemployment, having suicidal ideation. Some of us may have lack of familial support as well as lack of healthcare access. Also, the tendency towards negative health encounters. When we meet individuals who are not culturally sensitive to the transgender individuals, and they know that you are born male or born female, healthcare staff may opt to use those original names that they were assigned to at your birth instead of using your preferred name. So that doesn't encourage transgender individuals to come back to those facilities for healthcare, to disclose all the information about their health to this individual, to these doctors. And again, that it just only reinforces that sense of distrust that transgender individuals have towards the healthcare sector. And we want to and knowing that individuals of the transgender community, namely Native transgender women, have high risk for HIV infection, we want to encourage those individuals to be a part of the healthcare team, to come in for routine health examinations, to know that as part of her routine health exam, every 6 months when she comes in, she gets checked for hormone levels. She's going to get an HIV exam as well too, or an HIV test. Whether it's quick or whether it's through the blood, definitely is important to incorporate that into your discussion. And even as mental health providers, encouraging Native transgender women, have you had your examinations? Have you been in for a routine health exam? When was the last time you were tested for HIV? If, again, and David, you must tell me whether or not these discussions are appropriate for every individual that you meet who's transgender, but we can talk about it in a few. But encouraging that to happen in the healthcare sector is definitely important, and discussions, should the individual feel open to disclose that amount of information with you, only helps enhance that prevention aspect, getting people in to know their status. And even if they find out they are living with HIV at the time, encouraging them to go and be a part of, to adhere to the medication, to go and see their doctors as scheduled, and to continue to be monitored and continue to strive towards getting the detectable viral loads in their system and to get tested earlier and such. So we can go into that as well. The transgender community also experiences discrimination and as well as societal stigma. There's still that piece about, and I know that Caitlyn Jenner is out and proud and whatnot, but there's still a segment of the population that doesn't really understand the transgender population. And depending on the access to internet, depending on the access to public television and the likes of that, the stigmas, the discrimination may be higher in some communities who don't have ready access to all of that information, and who may not have access to that media. So again, let me just stress there again, healthcare provider insensitivity. Get your healthcare staff, whether they're in the mental health sector, whether in the primary care sector or in the infectious disease sector, get these individuals trained in how to deal with transgender individuals. There's also a lack of inclusion in data sets. There is, for the CDC, they have been able to allocate specific spots for transgender male to female, so it's self-identify, as well as transgender female to male, and to, of course, designate what racial ethnic minority you may be or not be. Not all healthcare institutions are doing this, so if you're working in the mental health, behavioral health sector, encouraging them, those amendments to your forms, to your demographic forms, may encourage transgender individuals to come in and, that this particular area is a safe place to be for my mental health concerns. So, and word of mouth spreads in this community like wildfire. If you act badly towards a transgender individual, other community members will know immediately. And if you are reputable and come highly recommended as a person who knows and has sensitivity towards transgender issues, the opposite will happen. Positive messages will flow within that community as well. So just wanted to make that little plug for that. Let's see. So this is a little graphic that I devised a couple of days ago, but we had been talking about it in our Native Transgender Network as well too, but the ideal picture of comprehensive healthcare. And again, this is a graphic that can be amended at some point. There may be other pieces of this that we need to add or some things that we need to remove. But for the optimal transgender healthcare experience, this is what most transgender individuals, whether they live on reservations or they live in urban sectors, should be able to participate in. Hormone therapy with the appropriate endocrinologist, routine and emergent healthcare. I know that in routine health examinations, sometimes the temptation to evade all of those breast care exams, prostate exams, cervical exams, depending on how this individual may be and where they may be at in their transition. Those things still need to happen for transgender individuals. And so, for example, I have been able to have my breast exams, but I also know that I still have a prostate that needs to be examined as well too. So just knowing that and just being able to advocate for that, but also encouraging your your clients or patients to, when you're in that sector and in that routine health exam, to know that those things need to be addressed as well too. We also want to include behavioral health. We also want to include substance abuse. When in transition, as David mentioned before, hormone levels change. For example, the transgender women, testosterone levels decrease and estrogen levels increase, with medication, of course. So in that process, substances may need to be used in order to cope with some of that stuff. If you come out, there may be a little more discrimination. Then maybe you may experience you may be just more sensitive to more stigma and such. So substance may be an issue there. Chronic disease management, such as HIV, diabetes, hepatitis C, those things also need to be addressed. Also cardiac issues. Things of that nature need to be addressed during these examinations as well. And also the option for traditional therapy. All of that needs to be offered to transgender individuals as well as other individuals from the LGBTQ two-spirit community. All of this needs to be offered. Of course, minus a few things in addition with the addition of other things as well too. So nonetheless, David, do you want to add anything to this?
No, because the big part of the behavioral health I'll cover when we get to those slides.
Okay. All right. Great. Thank you. Okay. So this is a picture I just wanted to show. I don't know why my slides didn't work before, but I couldn't import this picture for some reason, and I put it here. So mental health considerations. So here's a picture of some of the members of the Native Transgender Network. And if you are concerned about how we present ourselves or how we present ourselves at your presentation or in front of your staff, this is kind of how we would come, dressed as women or dressed as men, and we definitely have amended our lifestyles in order to be men or be women or somewhere in between, but we definitely are, our appearance is very much professional as well as reputable. So just kind of have a picture of what we look like. And I am in the middle, of course, with short hair, so I'm the only girl with short hair in that picture. Okay, so before I hand it over to David, I just wanted to add a couple things regarding mental health considerations. Again, there's going to be depression, switching hormones, switching lifestyles, and also just being a little more out there regarding who you want to be. It's more of an internal decision, but also as you outwardly express the internal decision, you may experience more depression, and that may be an ongoing issue. Suicidal ideation, do I really fit in this world? Am I an anomaly? So some of those things are coming up as well too. Using substances or abusing them as well too in order to cope with your transition, in order to cope with also not only your transition perhaps, but also maybe a new chronic disease. Some of these things may come up as well. Trauma therapy, depending on what he or she may have sustained as a child, as somebody who was an adolescent or somebody who was a young adult, or whatever stage of the game, trauma still is a big portion of that needs to be considered here. Let's see here. And some of the other things to also take into consideration, behavioral health. How do I live as a woman or a man in a society now? So those are some of the questions that I had. How do I live as a woman now? What is the best way to do this? Adapting to increased levels of estrogen to be more female, adapting again to levels of testosterone in order to be more male, adapting to gender confirmation surgery. There may be a process in there as well, and you as a provider may have to help guide he or she through this process as well. And how am I to deal with a chronic illness? Again, some of the things that I alluded to before, but these are things that impact transgender individuals. And he or she may bring these into discussion as you are conversing with him or her. Okay, and I'm going to turn it over to David. So David, you can take it over. Thank you.
Thank you. So one of the reasons I ended up with some experience in this field is that when I first came to DIFRAC, my very first clients were a couple, and one of the partners in this couple was a female-to-male transition. That's, they were born female but presented as male. They actually, when they got involved with Child Protective Services, they were both 17, and so this coupleship had existed since they were like 15. They had made arrangements that teenagers will make to ensure that they had a child through a friend of the male partner. But they ended up in CPS, and so I had to find ways to not only get them the appropriate kind of care that they needed from a mental health perspective, but also to reassure the court that even though the partner was not the biological father, that based on ICWA standards as the emotional, spiritual, and actual presenting father for this child, that, you know, it did not violate the ICWA standards when it came to identifying family, which they argued with me quite a bit initially. So when working with the clients, the big piece of this is distinguishing between the sex and the gender. When we're looking at the gender identity, it's one of the challenges we've got as people, look at a job application, you look at paperwork of, what's your sex? When we look at it from the terms of gender, that is the presentation piece of it. So the biological sex, when we look at that, that is purely based on the chromosomes, whether you're 2X or 2Y. The gender is that the beliefs, the expectations, the conventions that come tied to that. What are the cultural norms when we look at gender expression? And then that core gender identity. So how to identify, and so there'll be clients that will identify as male or female. It doesn't mean that that's how they were biologically born. There are actually some clients that are indeterminate. I worked with a client when I was doing my internship that presented strictly androgynous, that they weren't comfortable claiming either gender identity. And so as a counselor, and especially in the mental health field, these are things that, again, we need to set our own stuff and expectations of the client aside and really look at where is the client at that space and time, and what do they really need from us to help them get to a healthier place emotionally. And then the gender dysphoria, and this comes back to the idea of when we look at the DSM-5 diagnosis of gender identity disorder, that there's a dissonance to the person of what they were born biologically with and how they express that. And so, I don't feel this, and I'm struggling with what I need to express as. So from a mental health perspective, this is probably going to tie into a lot of the idea, where the depression comes in, where the potential risk of abusing alcohol or substances is. I don't know how to deal with what's going on inside of me. I don't feel like I should. So, if we're looking at the amygdala override, if we're looking at anxiety, depression, all of that, that's where we're going to get the greater risk of substance abuse, the greater risk of depression. And in our community, especially because natives have a high suicide rate, we're looking at even a greater increased suicidality for these clients. So big piece of this, so one of the things that I also do is I'm affiliate faculty at Metropolitan State University in the Human Services program. So a lot of these slides is what I actually present to my students. And this one's when we're looking at that internalized homophobia and the negativity. From a counseling standpoint, the process by which the transgender individuals come to accept their negative stereotypes, the myths, the misinformation, that inferiority that they may experience personally or socially based on this expression. And so when we look at that, if that's within them, it's going to be really hard for them to express it out. And so it's kind of from the standpoint of, if the battle is within themselves to accept who they are, it makes it even worse when the rest of society is not accepting who they are. So how do we help them get to a healthier place? And so part of that, when I look at it from a cultural standpoint, will tie into, some of these things. So the American Counseling Association, these are the things that they endorse. Having a strong understanding of the difference between sex and gender. Sex is pure biology, gender is that expression of. Eliminate the discrimination in the counseling setting. And so, for that first client that I had, here at DIFRAC, I was very careful on how we, arranged the appointments, arranged the offices. Very careful in, the use of pronouns, that I let them control that piece of the conversation. Questioning that DSM-5 inclusion of gender dysphoria, the partner in this particular relationship was white comfort. They always felt male, and so they always presented as male, probably as early as age 7. So, I realize for a lot of transgender people that seems really, really young, but for this particular client, it was a very strong identity, and it didn't matter what the biology was behind that. So using the DSM-5 gender dysphoria just would not have made sense. Careful consideration of their personal goals, their definitions, and those experiences are really, really huge with the experiences of discrimination, whether it comes from the community, whether it comes from their family. For a lot of people from very traditional families, this is a challenge in the Native community, depending on their individual tribe, may determine the level of acceptance or rejection that they feel that they're going to experience. And then more importantly, the client's existing resilience, that it takes a lot of strength to make the transition. And so from a strength-based perspective, what has gotten you to this point and what's helped you through to get here, because those are the strengths we're going to build on. This is how we're going to bounce back from, and whether it's a self-discrimination piece that you're experiencing, and more importantly, the discrimination and the challenges that you're going to face from, from the society around you. I use the term affirmative psychotherapy, so when I'm, especially when I'm working in professor mode, I've adapted this from a book by Clark. A counselor may or may not be primarily homosexual or trans. I've added the transgender wording to this, quote. In orientation, but he or she, but if he or she is affirmative by declaration, he or she believes transgender clients are not merely accepted, but must be appreciated. So when working with this client, that's the big piece of it. The affirmative counselor knows that there's no need to address the question of whether or not to be or not to be trans, that there may be some need to help the client find the way to just be simply the best person that they can be as an individual. And there's some, the challenge we have with that is there's some therapists that have the perception of we need to talk the person into the transition as quickly as possible, and that client may not be ready for that. So you want to meet the client where they're at and just affirming who they are and where they are in their current position and what does it take for them to get to their goal. Their goal may be just, I don't want to be depressed anymore. And so the topic as the counselor may never ever come to, their expression of gender. And as a counselor, it may be really, really hard for us to not want to drag that into the conversation. But again, it's affirming the client where they're at. So what is affirmative? And so these are kind of the things when I'm training students, that when we're working with clients in this community, that being part of this community is part of the normal range of human diversity. It is not a pathological issue. It doesn't mean something's wrong with them. They're getting enough, for a lot of members in this community, they're getting enough of that input already. The last thing we need to do as counselors is add to that. Recognize that sexual and gender minorities experience a lot of the social oppression that may play a role in presenting problems. And so this, again, as a family systems therapist, I'm not looking at just the individual. I'm looking at everything that shaped that individual, because it affects not only how I work as a therapist, but it also affects the outcome and the goals of therapy with the client. And then, more importantly, we need to appreciate the diversity within the sexual and gender minority communities, simply because, for them to trust the professional relationship we have as healthcare providers, more importantly, to agree to the collaborative partnerships that we need with a lot of external sources to help them get those resources, whether it's for medical, whether it's for support groups, whether it is for anything else that they may need to help them, again, express themselves as a better human being and however they identify. So we got to work on that. Did I repeat? No. So I kind of alluded to this earlier. Refer to the clients by the name and the pronouns they have chosen and prefer, and this is why it's important to ask, because you want to make sure you don't violate that sacred space with your client and the client relationship. Again, you're meeting them where they're at. That person-centered approach, most of us that go through training be counselors, especially on the LPCC side of it, person-centered approach is a big part of what we're going to do. Again, I'm focused on you. I'm focused on what you need from me as your therapist. Make no assumptions about their sexual gender identity or their decision of how they present. That is entirely up to the individual. And the big piece of this is familiarity with the resources that are available to them. So, where can they go to get it? If they have a hard time finding where appropriate endocrinologist for the hormone treatment, can we refer them out to somebody? If, in addition to the depression, if the substance abuse piece of that, what kind of support can they do to help find them, on a piece of that? Here in Denver, we have the Wellbriety group, which is, very Native focused. So it's not focused just on the addictions piece of it, but it's focused on from a cultural perspective, how can we integrate our spiritual walk with working, living a better expression of our culture and our identity as a whole. The non-affirmative stuff, and this is kind of the things that you just don't want to do, and I would say this is with any client, but especially with people from the trans community, lacking the knowledge about the gender and the sexual minority issues. That they're there, you need to educate yourself. When I had this first client, nothing in grad school prepared me for this is the very first case you're ever going to have. So it required a lot of consultation, it required a lot of education, it required a lot of time on me to actually look at the research, look at the data that's available. And even when I teach my students at the college level, every good research article should end with the more research is needed in this community. That is definitely the case. So always look for updated, newer material because the information is consistently changing. I would say in the last 3 years it has significantly changed. Therapists that don't work well in this community, they're not going to recognize that impact of homonegativity and that trans negativity on the client. And especially from the Native community, we add that on top of the impact of historic trauma and then any childhood trauma they may have experienced. Then we've created an amygdala override. We're creating a person that's going to always be in a state of near panic or near distress. And so just to engage them in good therapy to get to the cognitive piece of it, we have to have that awareness. Pathologizing the homosexuality or gender identity, whichever it is, again, this is not a pathology piece of it. It's just an expression, so how can we help them get to a healthy expression of who they are as a human being? Okay, there we go. And then some more of the what not to do. Don't be overly encouraging or discouraging about coming out. Again, you want to meet the client where they're at, so it is their decision, it is their goal. If the treatment goal the client tells me is I just want to work on the depression, then that is all we work on. Now, at some point, that conversation may be, okay, if you still have this battle going on within you, maybe helping overcome some of that depression is, finding the time and space for you to get comfortable with whatever that next decision may be. Pressure the client to conform to societal norms. This is, I'd say in a lot of areas, this is probably the bigger piece of it. Gender conformity may or may not be their goal either, and so as a therapist, don't want to force that on them. And then our comfort level. So if we're showing personal discomfort as a therapist or as a mental health professional with their behavior or the discussion of nonconformity, we cannot bring our personal stuff into the client relationship. And if it is that discomforting for you, then you need to be honest with the client and suggest that they refer out to a new therapist. Otherwise, you risk doing more harm than good working with the client.
David, can I add a few things to that?
Sure.
Okay, so in my personal experience, I had a counselor who started using my male name, and he knew exactly that I had a preferred name of Michaela and wanted to be called Michaela, but he still reverted back, and it was more than one occasion, and so I had to leave that entire discussion, but he never addressed it. He never tried to apologize for it. He just continued doing it. So things like that, without apologizing, without acknowledging it, definitely dampen and definitely will decrease the person, will only sever that relationship that you have with your client. So just things like that. Be mindful, please.
So person-centered counseling, this is a lot of big pieces, and the big pieces from person-centered counseling, I think this, again, would apply to any client, but especially in this community. That unconditional positive regard is the biggest piece that we have as therapists and as counselors that is going to help these clients, especially in the Native community. So if I'm going to meet you where you're at, and I'm going to affirm you and accept you just as you are. That congruence piece of it is huge. That I am consistent with my clients. It doesn't matter how they express themselves. It doesn't matter, whatever that is. I will accept you as you are, and I'm going to empathize with your struggle. Even though I may not have personally gone through that, I will have a sense of empathy and the simple fact that I'm here with you in that sacred space of why you're discussing this with me so I can help you travel whatever journey it is need to get to a healthier place. Adopt a subjective view of the client. And so, again, this isn't a targeted piece of it, this is what's wrong or this is what's right or this is what you need to do. It is a matter of being very subjective with the client so that they can guide the counseling process as they need, and I adapt the treatment plan accordingly. Emphasize the importance of developing positive self-concept. This is a big piece of it. in order for you to be in whatever state of transition that you're in, what is that going to look like for you, and how are you going to be okay with that? The belief in the client's potential to grow is huge. You can get to a point where you're healthy and okay with wherever you are at, or whatever you ultimately decide. It is not my goal to tell you what you should or should not do. And again, it goes back to, like I keep saying over and over again, it is client-directed. The client will tell me their goals. The client will tell me the direction that they need to go, and I will stay to that. That way it's never any personal agenda or anything that I may have brought into the relationship based on my experience that it could either negatively impact theirs or potentially steer their journey into a different direction that's not necessarily good for them. Cognitive therapy uses this a lot, and the cognitive therapy is generally to challenge those maladaptive beliefs that have been internalized. So how have they, from a negative standpoint, looking at their negative self-view based on their experience with homophobia, biphobia, or the transphobia? So, all of that input they're getting from the people that are not comfortable with their breaking outside the cultural norm. How has that affected you, and how have you internalized that? And how do we need to challenge that to create new beliefs, to create new positive experiences based on that? So where can we find the healing within you so that, you're finding within your own personal jar the positive inputs and less influenced by the negative inputs? And then multicultural mindfulness. And I do this with all of my clients regardless of what's going on. But becoming aware of their own biases, their own values, those own assumptions. As a counselor, we need to do this, especially from the non-dominant groups. Understanding their worldview. Here in Denver, we have an interesting mix. We have, a large number of different tribes represented. We have people that are third and fourth generation relocation natives, and then we have people who are first year, off the reservation natives in our community as well. So from that multicultural standpoint, for your people, for your tribe, for your culture, what's the appropriate way to work through this? What's the appropriate way to help you, for those who've made the decision to fully transition, what's it going to look like for you to have whatever you need to express this new identity in a way that's culturally appropriate? And then the skills piece of it, engage in appropriate interventions to effectively work with the clients. Because we have a large number of tribes here in Denver, I may not have enough expertise in how a Navajo would be, take care of that. So refer them to a Diné elder, somebody in the Diné community. Same thing with the Lakota community that we have. We have a large number of people here from Pine Ridge and Rosebud. So who can I help the person connect with to help that piece of it? If they've got family up in Wind River, what's that going to look like? Who can you talk to in that community to, again, help you get through that multicultural piece of it? Because here at DIFRAC, I'm using a broad, generic, pan-native lens. And so if they need a very specific one, it's, I do what I can to help them find that. Alderson, the things to keep in mind when working with the client, and again, this is probably going to sound repetition, but what defines the person's environment, both past and present, because in the family systems environment, we didn't grow up in a vacuum, so everything that happened around us as we were developing shaped who we are now and can shape what we'll become in the future, either good or bad, depending on how we work through that process. Who's the person that we're dealing with right now? And then take into account those environmental and personal characteristics. So what's shaped you? What's kind of created you? If I'm dealing with somebody that, in addition to working through the transition process, is struggling with alcohol or substance abuse, from a trauma-informed lens, is the trauma that they're struggling with the most coming from the discrimination from their identity, or is it trauma that came from the family system in any number of ways? So we've got to work through that trauma element. And then define the problems that the individual is presenting within their multicultural experience. So, you just can't have a one-size-fits-all. It's impossible. So again, the client will help you identify that, and you work within that realm. And then, that social justice model, as the therapist, as the counselors, this is kind of the realm that I live in, in a radical paradigm shift from the individualistic orientation. Mental health practitioners are increasingly being called upon to adapt the socio-political understanding of emotional and behavioral problems and to serve as societal change agents. So transforming the cultural context in which the sexual and gender minorities live in. As therapists, we need to grow with that, and we need to be able to adapt, especially in the Native community, because it's there. And so, if we've already got, a historically oppressed culture struggling with gender identity, the last thing we need to do is add to that trauma that they're going to experience based on lack of acceptance.
Okay, great. Thank you, David. And so to round it all out, we just wanted to, again, reemphasize these practical tips. Number one, refer to clients by the names and pronouns they have chosen and prefer. Utilize a person-centered approach to gender expression by aiding clients in the exploration of all options. Number three, make no assumptions about the client's sexual/gender identity. And number four, be familiar with local/regional resources. So in the event that a person discloses, hey, I have real concerns about HIV prevention or HIV treatment, be equipped with some of those places to send these individuals for that. Or if I need help finding an endocrinologist, I need somebody who is trans-friendly in that particular realm, having that information at hand is definitely important. And if you don't know, ask some trans individuals that you may know of in your community who have that information, who may be active in those arenas, because word of mouth, again, really does help. And so utilizing the resources, utilizing their knowledge base definitely helps in that regard. So other than that, I think we are at our time. So these are the resources. And again, there's some from the CDC that I've put on my previous slides, but didn't acknowledge here, but these are the resources that David utilized in his presentation as well, and some of the books. So we just wanted to say thank you for your time this afternoon. And here is my address, mgrey, M-G-R-E-Y, at nnaapc.org, and David D. Welch at diaphragm.org. So also look for the National Native Transgender Network Facebook page, NNTN, and see if you have any additional questions for us that we need to address, either email us here or tag us and find us on Facebook. So thank you very much for your time, everyone. Have a great afternoon.
Wonderful. Thank you so much, Michaela and David. It was a really wonderful, informative session. So we do have some questions that have come in, and if others have questions, we've got a little bit of time to address those. So feel free to type those into the Q&A pod, which is just to the right of the presentation. So I'll start with the questions we have so far. Our first question is, as a parent of a transgender child, how do I go about addressing preferred gender pronouns without outing my kiddo? And then she goes on to be specific about when attending appointments and or addressing school professionals.
Okay, so obviously the child may already be experiencing some of that as well. So having a frank conversation with the child may be in order. Asking, hey, what's going on here? Are we entering the transition process? And there may be some additional education the parent may have to go through in order to get to that point, in order to be able to utilize some of that term. So David, do you have any additional advice about that?
A big piece of that, I would say, is the child is probably not as aware of the pronouns as you are. Mm-hmm. So, that would go to a matter of, with a lot of the kids, what names do you prefer to be used by? And so if I'm talking to a doctor, instead of referring to, using words like he or she, addressing the name, and that way, the child is acknowledged as part of the conversation. They don't feel excluded from that. And so, again, like with my one client, that, the expression came out as early as 7. And so, having it probably helped that the client had a very generic name, so it wasn't gender specific with the first name either, so it was just much easier to do that. If the child has a very gender specific first name, then what other name can we use? And, it doesn't necessarily need an explanation to the school teachers or whatever that the person prefers to be called this. It's my nickname, that's just what it is. And that way, when the child goes through adolescence or adulthood, and at whatever point the child feels ready to make the decision, I'm fully out, they're going to be more comfortable with that decision because they're going to feel fully supported by the parent because that conversation has always included them.
Yeah, definitely very appreciative of your keen awareness in that situation. So thank you.
Great. Our next question is about asking clients about their identity. Would you recommend asking every client about their identity? And then they say, I ask because I work in a conservative community, and although I believe in asking everyone, I'm not sure how well it will go.
Let's see here. I think part of that could possibly be initially disclosed at demographic time when the forms are the forms are dispensed. But also, if you really want to ensure that he or she feels comfortable in talking with you and disclosing information with you, I think those initial discussions may just have to come up. And David, would you say the same thing, or how would you advise?
Here at DICAC, it's actually part of our demographic format intake. And the demographic piece will ask male, female, transgender, or they can choose not to confirm either way. And if they choose not to specify, then I know that's not a conversation they're comfortable having yet.
Yeah. And also, yeah, that's a good point. But also knowing that if you've already had that conversation with him or her, that may change the next session that you see him or her. So just asking the initial question, what name should I refer to you as? What kind of pronouns are you comfortable now with? I think we definitely break down some of those initial barriers. So if you can't capture it at demographic forms, maybe capturing it in your own sessions would be most useful.
Great, thank you. Our next question is, does IHS provide cross-gender hormone therapy, and is there broad variance in whether or not Medicaid covers this? And then they note that Maryland used to, but now does not.
Okay, so I know that Colorado, some of the trans women have been able to access hormones utilizing Medicaid, and I believe, and I might be wrong about this, their names may not have changed legally in order for that to happen. I did it the other way around. I had to change my name. Actually, no, I didn't. I utilized trusted healthcare providers. Indian Health Service does dispense hormone therapy, but I think in very small settings. For example, Albuquerque has that capability, as well as Phoenix. Beyond that, you would just have to go to the client would have to approach the health center staff to see if that's even a possibility and see if there's somebody on staff who is able to manage that therapy, and also may have to have another conversation with the pharmacy managers and the pharmacists to say, well, I know it's not approved for this diagnosis right now, or actually I think it might be. But can I access my hormones here? And so whether it has to be a treating physician who is willing to manage that therapy in order for them to gain access to it, that's the most important piece of that.
Great, thank you. And we've got one more question. What do you suggest for housing when a transgender individual checks into treatment?
I'm sorry, say that one more time?
Oh, sorry about that. What do you suggest for housing when a transgender individual checks into treatment?
Okay, David, do you have any thoughts on that?
If they're in transition and they have made the transition, if they identify as female, in a perfect world, you would house them in a female room. It's the challenge that you may or may not have is if it's a shared room, will the roommate be comfortable with that? And so, in most mental health treatment settings, that's part of the challenge that we'll have. And we could find that, just with intertribal rivalry. So we don't even have to look at this from the trans perspective. Knowing the clients that we have, and especially in residential treatment, the more we know the residents, the more informed we can make that decision when that time comes. For some, it may simply be more comfortable for not just the residents, but especially the client, if we can arrange, private room, whatever, sacred space for them until at such a time either the other residents get to know the individual and accept them. And that's one of the reasons that ongoing training, ongoing education for all of us in the mental health treatment field, it's something we're going to have to learn to work with because it's not something that's just going to go away. And as more and more people learn that they can be who they are, we're going to have to find ways to work with that.
Yeah. Okay. Thank you very much. And Kate, I just wanted to refer back to the first question that that was just posed to us regarding the parents with the school administration and all of that. I think after you have an initial conversation with your child to figure out exactly what needs to go by, what pronouns are most comfortable, then the conversation with the school official should be held next. And I think it needs to happen sooner than later. But again, timetables are different for everybody. Things are different, so go with what your child is with him or her with her timetable and such. So.
Wonderful. Great. Thank you so much for those questions. And thank you so much, Michaela and David, for offering your insight and expertise in this area. And with that, we will end our session today. I just want to remind everyone that you should be redirected to our survey after we close out. So please take a couple minutes and just let us know what you thought of today's presentation. And we will be sending out some follow-up information, which will include a link to the recording of this presentation, so you can view it again, you can share it with others, and we'll also have handouts of the presentation that you can refer to as well. So some of those resources and things, if you miss those will be available to you. And with that, I'll just thank Michaela and David again, and thank everyone for joining us.
Thank you, everyone.
Thank you.
Wonderful. Thanks so much, and I hope you all have a great day.
Okay, are we done?